morning, everyone. It's my pleasure to introduce Dr. Wackym from Rutgers University. He's a professor and chair of Department of Otolaryngology, head and neck surgery at Robert Wood Johnson Medical School, and senior member of Rutgers Brain Health Institute. He earned his medical degree at the Vanderbilt University School of Medicine, residency training UCLA School of Medicine, and his otology and neurotology skull-base surgery fellowship at the University of Iowa. Dr. Wackym's clinical interests are cochlear implantation and skull-base surgery, with particular focus on surgical management of patients with superior semicircular canal dehiscence and other third window syndrome disorders. Dr. Wackym, thanks again for joining us this morning, and we are looking forward to your talk.
Well, thank you so much. And I really appreciate the opportunity to speak today. I actually became an otologist because of a research experience I had at the House Ear Institute in 1983 when Mike Glasscock gave me $2,000 to come spend the summer there. And Mike McKenna was actually a research fellow there at the time. The last time I spoke in front of the faculty of the House group was actually 35 years ago, which seems staggering to me, but it's a pleasure today to be able to share some of my thoughts about third window syndrome, including superior semicircular canal dehiscence, but so much more. I have nothing to disclose. I wanted to provide an overview and first briefly go over the anatomy, talk about the consequences of vestibular asymmetries, introduce third window syndrome, reviewing the phenotype, talking about superior semicircular canal dehiscence, plus the other third window syndrome disorders that can be seen with a CAT scan, and introduce the idea of a CT-negative third window syndrome. Talk about management and outcomes, and finally introduce a new animal model of superior semicircular canal dehiscence. As everyone in the audience knows, we have three rotational receptors in each inner ear, and they're paired with a specific receptor on the opposite side. And the same is true of the otolithic organs, of which there are two on each side, likewise paired with the receptor on the opposite side. And so when there's an asymmetry, so again, with the receptors, they're constantly discharging, constantly sending nerve impulses back to the brain, but they don't act on their own. Each receptor is paired with a specific receptor, and the reason that they're organized that way is as we turn our head or tilt our head, the firing rate goes up on one side, goes down on the other, normally equal and opposite. If there's an asymmetry with the rotational receptors, you get true rotational vertigo. But if it's a gravitational receptor dysfunction type of vertigo, patients will describe a rocky, wavy, tilty feeling. Sometimes you feel like they're pushed or pulled or tilted or flipped. The floor falls out from under them. They float. Those kind of illusions of movement. With both, the autonomic nervous system is triggered, but with otolithic asymmetries, it can cause central nervous system disruption that produces cognitive dysfunction, spatial disorientation, and anxiety. We also know from the literature that rotational receptor asymmetries do not induce this cognitive dysfunction. There have been neuropsychology studies and other validated survey instruments used in Meniere patients, normal controls of vestibular migraine patients, and the cognitive testing showed no difference between any of these three groups. The Beck depression scores were likewise not significant. Anxiety scores were significant, but again, no cognitive dysfunction reported in these rotational receptor asymmetry type of patients. Now, the otolithic asymmetry patients experience cognitive problems that can be described as difficulty with short-term memory, problems concentrating, difficulty prioritizing tasks, difficulty reading. They can have expressive dysphagia. Their attention span is limited. And this is also interesting. Women naturally have the ability to listen to more than one person speaking at a time, but men don't. And I do relish being able to explain to women that now they know what it's like to be a man in terms of their listening ability. With kids, often missing days of school, big change in their academic performance. They have migraine headaches, light sensitivity, nausea, often labeled as conversion disorder. They can act out or be violent when they're exposed to loud sounds, and some get labeled as autistic. It also causes spatial disorientation. And these patients can feel detached. They have difficulty judging distances. They can even have out-of-body experiences, which sounds crazy, but I'll circle back on that in a little bit. With third window syndrome, patients are sensitive to loud sounds. Loud sounds can induce tilting or rocking, nausea, dizziness, pain, headache, falls, spatial disorientation. They also hear internal sounds unusually well, their heartbeat in particular, breathing. A third can hear their eyes move or blink, and we'll talk about that a little bit later as well. Chewing can be so loud they have to stop chewing to hear what someone else is saying. Their voice can sound resonant. When some patients are singing, it can induce the dizziness. And a good screening tool is to use a 256 hertz, not 256, sorry. Uh, 256 and 512 hertz tuning forks and apply these to the knees and elbows. And often the patients can localize the sound and either feel it or hear it. And sometimes, particularly on the elbows, it can induce the dizziness. They can have cognitive dysfunction, fuzzy, foggy, spacey out of it, memory's poor, concentration's down. They can have ear pressure, which is really in lymphatic hydrops type of picture. They have an inner ear conductive hearing loss that we'll touch on in a little bit. They can have tinnitus. They can have migraine headache, but also interestingly, they can have the three variants of migraine: hemiplegic migraine, which is very rare; ocular migraine, which is relatively rare; vestibular migraine, which is very common. Not very common, but it's more common than ocular or hemiplegic migraines. But it can confound the clinical picture because on top of their sound-induced dizziness, they can have true rotational vertigo, and it's usually because of vestibular migraine. So Tullio, of whom Tullio's phenomenon has been named, did early experiments. This is from a paper published in 1929, where he took pigeons, created a left superior semicircular canal dehiscence. Here you can see the pigeon's head with no sound. Here with sound, it induces head tilt, which of course is otolithic dysfunction. If you paralyze the canal with cocaine, no head tilt is observed. But this really laid the groundwork for Lloyd Minor recognizing superior semicircular canal dehiscence in 1998. And so with the sound pressure that is delivered through the tympanic membrane and ossicles, this, of course, normally stimulates the cochlea, and we have the oval window moving in while the round window moves out because this fluid cannot be compressed. But in the circumstance where a third pathologic mobile window exists, some of that pressure is shunted out through that, and that's what asymmetrically stimulates the vestibular end organs. So I mentioned Lloyd in 1998 first described this. In a larger series in 2005, he introduced the inner ear conductive hearing loss that's seen, also lowered vestibular evoked myogenic potential, CVEM thresholds down to 81 plus or minus 9 decibels. Now, this is also interesting to me because somehow without the literature being involved with this, often a standard of 70 dB or 60 dB or 65 dB is considered abnormal in these patients. But again, in this series, you can see a lot of those patients with confirmed superior canal dehiscence would have been missed if that standard was held at the time. Dennis Poe's group has also expanded our understanding of this disorder and introduced the idea of autophony and the blocked ear, the inner ear conductive hearing loss 86% of the time. 4 out of the 65, and this is also interesting, had the third window syndrome findings, but had normal CT scans. And I discussed this with Dennis, and he didn't do anything about this because he wasn't sure why this would occur. But I'm going to introduce some information shortly that will help provide some insight into that. The Michigan group also focused on abnormal electrocochleography findings in patients with superior semicircular canal dehiscence, and only 4 of the 14 ears with superior canal dehiscence had surgery, and the hydrops resolved in those patients. We've looked at a number of patient cohorts over the course of 4 separate publications that looked at CT positive and CT negative third window syndrome. We've done neuropsychology testing on patients, which I'm going to present some of that data, and also consistently used validated survey instruments, both the dizziness handicap inventory as well as the headache impact test. One of these papers, the 2017 one, was about 12 patients who had comorbidities. that were largely psychiatric, and I didn't have time to include that, but some of those were pretty fascinating patients that really had different outcomes because of the underlying traumatic brain injury, increased intracranial pressure, but also some significant clinical psychiatric diagnoses that were outlined in that study. But this isn't a new problem. There is a paper that looked at the CTs of 10 Egyptian mummy heads. There was one male that had a superior semicircular canal dehiscence and another male with a near superior semicircular canal dehiscence. So it's remarkable that clinically we didn't really recognize this until Lloyd's discovery in 1998. And so I would submit that we really should replace superior semicircular canal dehiscence syndrome with third window syndrome because the phenotypes are exactly the same. There are now 16 different CT positive sites that have been described in the literature, but there still are some that can't be seen on a CT scan, which I've termed CT negative. And here you can see a summary of these sites. The semicircular canals are a common location of these, but also more unusual ones. I'm going to talk about cochlea-facial nerve dehiscence a little bit later. Other labyrinthine sites like wide vestibular aqueduct, lymphatic sac jugular bulb. A former research fellow at the House Ear Institute, Arun Gadra, has described a post-traumatic hypermobile Stopes footplate, and also wide Modiolus with X-length Stapes gusher. I'm not going to focus on this very much, but I only wanted to make the point that in 4N1 patients, there were 502 temporal bones that were associated with third window syndrome. And you can see the prevalence of these. By far and away, superior semicircular canal was the most common, as well as, and if you aggregate those, you're at 60% of the disorders. But I also wanted to make the point that there are less frequent but concurrent second sites of third window syndrome that are probably responsible for the roughly 10% of patients who don't do well after surgery for superior semicircular canal dehiscence. And I have analyzed that and reviewed the literature in that context, but did not have time to include that in the talk today. And so here are just some sites of examples of sites, superior canal. Here you can see a posterior semicircular canal dehiscence. And also I should point out, posterior semicircular canal dehiscence in young children is relatively common. This is typically not associated with a third window syndrome and also typically closes spontaneously. Here an example of a posterior canal jugular bulb dehiscence, an example of a carotid cochlea dehiscence, and also a cochlea-facial nerve dehiscence shown here in the center. And again, I'm going to circle back and talk more about cochlea-facial nerve dehiscence shortly. And so what about the CT negatives? What it could be? What could it be? Possibly Modiolus. I, from personal experience, have labeled patients as being CT negative, but upon past review of past patients, a number of these are cochlea-facial nerve dehiscence, a congenital or acquired membranous Stapes footplate, perilimb fistula, which of course has earned a very bad name in our communities. But by definition, all of these third mobile windows are a perilimb fistula because there's a hole in continuity with perilymph. And so before thinking about surgery, you really need to have alignment in decision making. You want all the symptoms to be consistent, or most of them be consistent, having the diagnostic studies with the inner ear conductive hearing loss, the elevated amplitude on OVEMP and CVEMP, as well as a reduced threshold on CVEMP, as well as the imaging studies. And I'm going to show you some examples of why it's important to image these temporal bones in 4 separate planes shortly. Being more cautious with near dehiscence patients, considering multiple sites of dehiscence is important in patient counseling. And then it's also a challenge in the elderly and some with recurrent or persistent symptoms after surgery. So there are non-surgical options, earplug for sound attenuation, ear planes for air travel, reduce their exercise and exertion, education about their disease, correct their postural discontrol, and that's the role of vestibular rehabilitation, and don't really have time to talk about postural discontrol after vestibular asymmetries, but that's another hour talk, which is an important part of most of the patients that we see who have had vestibular dysfunction. Medical management, especially with sites of dehiscence that are not a superior canal, treating them as vestibular migraine patients medically, and you can see the range of things that can be used to help prevent these migraines from occurring. 40% of migraine patients are deficient in magnesium, so magnesium oxide or glycinate or something that patients should take daily. Having patients identify triggers, and you can see some of the more common ones shown there on the screen. So what about surgery? The dehiscent site with a superior canal can be accessed directly through a middle fossa approach. Some have advocated resurfacing of the superior canal, but there have been problems with resorption of material. I recently reviewed a paper using hydroxyapatite from Yale, and even though the ototoxicity of these man-made materials is not known, they actually had excellent outcomes in resurfacing these superior canal patients. Transmastoid plugging of the superior canal can be used, although surgically it really doesn't make much sense to me since you're having to drill 2 additional holes in the superior canal and plugging both. And the morbidity of a middle craniofossa craniotomy is very minimal and should be able to be performed within 2 hours surgical time. And most of the effort is getting there, and the plugging and resurfacing is the minor component of that operation. Some have advocated direct reinforcement of the oval window with superior semicircular canal dehiscence, although that literature is mixed and not very adequate, of the round window. With hypermobile stapes footplate, oval window reinforcement has been beneficial, and that's the work of Arun Gatra. So I'm pretty conservative with the management of patients with superior semicircular canal dehiscence. I really only have patients select surgery about 40% of the time. And over this February through November 25 interval, I've operated 216 patients with confirmed superior semicircular canal. So again, alignment of decision-making with clinical diagnostic and radiographic features, failure to respond to medical management. And with all these patients, I do structured interviews before and after surgery regarding their symptomatology, as well as integrate the validated survey instruments I've mentioned before of the DHI and the headache impact test. So I do a classic middle fossa craniotomy. I plug the both limbs of the superior canal with fascia, resurface with fascia, and then resurface the entire top of the temporal bone with hydroxyapatite cement. Very often, especially in adults, there will be small encephaloceles and multiple temporal bone defects, and gel foam is placed through these to maintain air spaces after the gel foam dissolves. And the dura is resurfaced with dura matrix, and then a cranioplasty is performed. And so I started seeing a lot of these patients and started seeing a few patients that had everything. I swore they were going to be a superior canal dehiscence patient, and all their diagnostic studies fit with that, except the CAT scan, which was normal. And so that led to us reporting a series of 6 superior semicircular canal dehiscence patients who are compared to 6 CT-negative third window syndrome patients. And this is focused on the CT-negative cohort, but they were all the same. They had the inner ear conductive hearing loss. They heard their tuning fork in the head when applied to extremities. They had autophony. A third of them had the ability to hear their eyes move or blink. So everything looked just like a superior canal dehiscence patient. For the CT-negative ones before surgery, they failed vestibular migraine management. Most of them had a history of trauma. All of them had light sensitivity, severe headache, cognitive dysfunction, and spatial disorientation. And all of them had sound-induced gravitational receptor dysfunction type of vertigo. And so superior canal dehiscence managed as I described before, the CT-negative ones shown here, but I'm just going to go to the next slide because it actually visually shows you this, and I'll just talk through that. Oh, sorry, not the next slide, but maybe the one after. And so here is an example of a left-sided CT-negative patient. I have a great video of her, and actually have an anonymous YouTube channel called Ear Information, altogether one word, on YouTube that has a number of patient videos before and after. And so here, just an example of the increased amplitude that you see in the C-vent on the affected side compared to the normal side. Normal, no inner ear conductive hearing loss, left inner ear conductive hearing loss shown there. And so here's that slide that I promised earlier. So you can see the bony overhang in the round window niche. This is drilled away to be able to fully visualize the round window. CO2 lasers used to remove the mucosa so that the tissues that's placed there will have an opportunity to scar to the bone rather than being on top of moist mucosa. And a flattened perichondrial graft used in a fascia press is used to cover the round window, but extend all the way around this on bone. I use a 2 millimeter skin biopsy punch to collect conchal cartilage, which is split in half to make it thinner, and that's placed over the round window. And then a series of small loose areolar grafts that are alternated with fibrinogen and thrombin in them is used to overfill that space, knowing that the body will resorb a lot of that tissue. And so one of my favorite surgical heroes is Halstead, first chair of surgery at Johns Hopkins Hospital. And this is one of my favorite quotes. If you put perhaps before a statement and the statement turns out to be true, you get credit for making it. If it turns out to be false, you won't be blamed. So here's the statement. Perhaps the Modiolus is the site of a CT-negative third window syndrome. And you can see our current limitations of a high-resolution temporal bone CT do not show the exquisite anatomy that a micro-CT can show of a human temporal bone. And the only downside of a micro-CT is the patient has to be cadaveric before that imaging study can be performed, which is not of any clinical use to us currently, but it may be that this site is where this can occur. And so Pico from Finland has done a number of studies that we can't do in the US, and injecting gadolinium into the middle ear and then watching this over time. And of course, the reason for doing this was to try to identify lymphatic hydrops, but over the course of 24 hours, the gadolinium will pass from the cochlea through the Modiolus into the internal auditory canal. So there is some natural communication between those fluid-filled spaces. Sumit Dasgupta from England has reported children with large Modiolus and same kind of VEMP findings and inner ear conductive hearing loss is seen in those patients. And those are Modiolus those patients have Modiolus that is easily visible on a CAT scan. So I promised to talk about cochlea-facial nerve dehiscence, which is what I'd like to do next. And so in 2014, Bob Young, also here at Rutgers, first described this. There were two patients. They had all third window syndrome symptoms. They had an inner ear conductive hearing loss, reduced thresholds by CVEMP. No surgical management was taken because, the morbidity associated with plugging that would result in facial paralysis and hearing loss. And patients were not interested in that appropriately. Subsequent study that he did with Johns Hopkins looked at the incidence or prevalence of cochlea-facial nerve dehiscence in a temporal bone cohort of 1,020 temporal bones, and you can see pretty unusual at 0.6%. Yeah. And so in 2019, we published a cohort of 8 patients who had a cochlea-facial nerve dehiscence and 8 patients who did not. And with this, you can see the mean age of basically 25, all had a history of trauma. All of them had that round window reinforcement surgery that I described. You can see the average CVEMP threshold was reduced in the operated ear compared to the unoperated ear. And something that was very different from superior canal dehiscence, lymphatic eye drops, normal electrocochleography was very unusual in only 1 out of the 8 operated ears. And I'm showing you this figure not so that you can see in detail, but only to make the point that using axial orientations, coronal orientations, the postural orientation, as well as the Stimber's orientation for both the right and left is important, because some of these sites of dehiscence are quite small, and unless you see it in all 4 of those planes, it may not be real. And here, just a blown up view of a cochlea-facial nerve dehiscence. Normally, you can see a partition between the facial nerve and cochlea, but in these sites of dehiscence, there is no partition that's there. And so here's just a video of a 16-year-old that was thought to have conversion disorder. And this is one of those I thought had a perilymph fistula before going back and reviewing that she, in fact, had a cochlea-facial nerve dehiscence. And she had a concussion, had problems with memory, et cetera, recovered spontaneously. December, had vomiting with the flu, had the onset of migraine headaches, speech production and fluency problems, and gravitational receptor dysfunction type of vertigo. And Dad took a lot of videos of her. And that's her autonomic dysfunction. Pretty severe migraines, huge workup. Often the response was nothing wrong with you. Ultimately, she was labeled as having conversion disorder. They recommended psychiatric intervention. She wasn't able to go to school. Obviously, big impact on her quality of life and functional capacity. And so I repaired what I thought was a perilymph fistula in 2013.
About 6 months after my surgery to repair a perilymph fistula in my right ear. Before the surgery, I missed a lot of my school. Multiple noises and loud noises bothered me. I couldn't handle them. I also couldn't read, write, or at times even talk or walk. Now I'm going to school every day. I am keeping up with all of my classes. I don't need more time. I can read and write and talk perfectly fine and walk as well.
What about headaches? Did you ever have trouble with that?
Oh, I had lots of headaches, really intense headaches before the surgery, and now I have no headaches almost every single day.
And she now lives in Los Angeles as a graphic artist working for Disney and continuing to do well. So what about measuring headache? I mentioned headaches pretty common in these patients, and it was interesting to me to learn that there really aren't very many validated survey instruments that look at the effect of intervention and outcomes, but one easy one is the headache impact test. And so there are 6 questions that you can see there, and you can see the scoring of these, with class 1 being the best, class 4 being the worst. And so with that cohort of cochlea-facial nerve dehiscence, you can see the individual patient data. I just wanted to call out a couple of these. And also, first, I'll just say there was a highly statistically significant improvement of their headache as measured by the headache impact test score. But I just wanted to touch on a couple of these patients, because when you're talking to patients, they'll often tell you everything's great, doing well. But they may not be doing as well as they claim to when you look at their headache impact test scores with some objective data, which just underscores the importance of incorporating validated survey instruments into your outcomes research with these patients. The DHI. So this was first published in 1990. It was designed as a self-assessment inventory the goal was to quantify the self-perceived impact of dizziness on everyday life. It was also designed to try to quantify the effects of treatment to the vestibular dysfunction And the rationale was really, if you have effective management, it should be reflected by an individual's ability to resume their premorbid vocational or recreational activities. And so here you can see there's a highly statistically significant improvement in their DHI scores in this cohort of 8 patients with cochlea-facial nerve dehiscence who had round window reinforcement surgery. And earlier, I also mentioned about cognitive dysfunction. And so this was especially interesting to me. And so I'm going to describe a study that was longitudinal in nature that looked at the outcomes of cognitive function and dysfunction before and after repairing otic capsule defects. After my fellowship at Iowa, I joined the faculty at UCLA, and a patient drew almost this exact same image, the one on your left there, of the disorganized thinking. But this was a cartoon I saw in The Economist quite a while ago. And instead of the ordered sequential thought to voice action in the patients with these cognitive dysfunction because of third window syndrome, their thinking is more muddled. And so again, with this study, we had patients who had superior semicircular canal dehiscence that were pure. We had pure CT-negative third window syndrome patients, and we had another cohort that had both. They had a superior canal dehiscence repair and plugging, did well, some pressure event later, developed a CT-negative. And so all these 3 cohorts were included in this study. We did neuropsychology test batteries before and every 3 months after, up to 12 months. And superior canals were plugged. The CT-negatives treated with round window reinforcement. Which I guess I probably shouldn't have included this slide because it's redundant, but I have described both this superior canal plugging and the round window reinforcement techniques.
Had a lot of difficulty with my cognitive skills. Thinking was extremely difficult for me. Even speaking, I slur my words or stumble over my words. I also had these weird kind of out-of-body experiences where I was viewing myself in a room with other people in there, but I felt like I wasn't actually in my body.
And some of these symptoms just sound crazy when you hear this from patients, but I didn't have time to include this, but there was a 15-year-old that was born with a superior canal dehiscence, and she had out-of-body experiences every day until her canal was plugged and she recovered, and she didn't have them anymore, and she actually missed them because for her that was normal. And so we use the Beck's Depression Inventory, Dulles-Kaplan Executive Function System, use the Wide Range Intelligence Test, the RIT, to assess IQ, did RAML, the Wide Range Assessment of Memory and Learning, and included all 4 domains of verbal, visual, attention, concentration, and working memory. As expected, there was no change in their IQ before and after treatment. But there were statistically significant improvements. And here are the Dulles-Kaplan executive function. You can see red is both superior canal and CT negative. The blue is a pure CT negative with round window reinforcement, and red is both. The dash green are the pure superior canal dehiscence patients. And you can see that is true for the motor score as well as the number letter score, with some differences in time course. And I'm going to give an example of this number letter score in just a moment to be able to show you what that looks like. And so this is from a 12-year-old boy who had a right cochlea-facial nerve dehiscence and a left CT negative, third window syndrome after a snowboarding accident, typical sound-induced nausea and gravitational receptor dysfunction, could hear his eyes move, plagued by cognitive dysfunction, migraines, and nausea, had an inner ear conductive hearing loss. The VEMP, couldn't do it without symptoms. CT, no superior canal, but had a right cochlea-facial and a left CT negative. And so here's an example of this number letter score. So he drew it, but this is the way it should go from 1 to A to 2 to B, etc., until you get to 16 and P. And so it took him 3 minutes, 22 seconds to do this task. He made 24 errors and importantly had no insight that he made errors. After treatment, you can see what this looked like. And so he did, He did this in a minute 38. He had 2 errors, but self-corrected those, which apparently in the scoring is important in that process. But this just provides some objective information of how his thinking improved post intervention. And he also had been an A and B student, but became a C and B student, and then returned to AB status after his recovery, and his symptoms resolved. And going back to the data from the 3 cohorts, this is the Beck's depression inventory score. So high scores are bad, low scores are good. And you can see all 3 cohorts had a highly statistically significant improvement. The RAML verbal scores, you can see there are different trajectories here. And I'm going to hypothesize with these superior canal dehiscence only patients, why there was a lag before they started improving. And so you can see with visual, verbal, and attention, there were differences in that recovery process, but consistently there was recovery post-intervention. And so one possible reason why the pure superior canal dehiscence patients took longer to improve was a cognitive vestibular compensation hypothesis. And with that, there's thought to be a limited quantity of cognitive resources that can be allocated to the cognitive tasks during the compensation stages, which took away from the ability for the cognitive portion to recover, therefore having the delay. With these, just to show the DHI and the headache impact test scores were highly statistically significant in regard to their improvement post-intervention. And so in the remaining moments, I'm going to talk about some, was there a question? Or clearing throat? So in the remaining moments, I'm just going to talk about a new model of superior semicircular canal dehiscence, which we've created in a gerbil. And this first of 3 publications is related to reversible diagnostic findings that are characteristic of patients with the disorder in this model. And so there had been a couple of papers that had animal models of superior canal dehiscence, and they all described CVEMP results. Only one of the papers actually showed the data, and it was just noise. But this also underscores the importance of having clinicians involved in basic research, which wasn't the case with the papers that were published, because a CVEMP depends on an inhibitory or relaxation potential being measured in these patients. And so the patient actually has to actively use their neck flexor muscles to be able to have them contracted, to be able to measure the relaxation potential, which of course can't be measured in anesthetized animals. Now, from the old literature, I found that the neck extensor muscles actually have an excitatory potential. And so we developed what we term a C+ VEMP measurements using these neck extensor muscles. And so this is excitatory, so it's present when the animal is asleep, which allowed us to measure the VEMP responses. Now, with inner ear conductive hearing loss, with animals, you can't do bone conduction thresholds in a small rodent, but we did observe a reversible low frequency hearing loss that can be measured by ABR, which reflects this inner ear conductive hearing loss. And so with this model, I surgically create a superior canal dehiscence in the superior canal, which is anatomically more accurately the anterior canal, in a gerbil. And then we also discovered, with the data, we were confused why these animals had the problem and it went away about 14 days afterward, only to find out, as I'm going to describe in a minute, the bone regrew. And so this provides a unique recovery model for studying these phenomena. And so we looked at auditory and vestibular and cognitive function before and after in a number of these studies. So as I mentioned, the superior canal is fenestrated with a 1 millimeter diamond burr. The tympanic bulla is the route to get there, and I'll show you a picture of that next. And then the bulla is reformed by gluing silastic over this. And again, the testing for this particular study included the ABR and the C+ VEMPs. I'll briefly describe another study that was published subsequently about auditory and visual decision-making tasks. And so here you can see what this looks like after the fur is incised. And then the bulla is under here, and so the muscle is cut, the bulla exposed and opened with a diamond burr. And you can see the intact superior semicircular canal here, the fenestrated canal, and there is bone debris that's left here, and I'm going to talk about that in just a moment, the significance of that. And then that air-filled space is reconstituted by gluing silastic over this, and you can see that quickly fogs up, reflecting the humidity of the bulla environment. The muscle is then glued back to the skull, which allows us to be able to measure those C+ VEMPs after a day of recovery. So I'm not going to go through this in detail, but this just illustrates the large opening that regrows over time to become reconstituted. And so here are ABR detection thresholds preoperatively early on at 7 days after the fenestration. You can see there's increased threshold, poor hearing in those animals. And then over time, that drifts back down to become non-significant at 21 and 28 days here. Similar story with the CVEMs. So preoperatively, early on at post day 7, you can see increased amplitude of the VEMPs, and then that drifts back down toward baseline and becomes non-significant by post 21 and post 22 days. I'm not going to discuss these two panels, but I'm just going to touch on this one. And so if you look at the data by day and plot that against ABR threshold and CVEMP threshold, you can see that early on the worst results are there, and over time this drifts back down to the preoperative values. And so we also did micro CTs of these animals to try to get a better understanding of why this was reversible. And it was pretty interesting, the data. And so here is an attenuated micro CT where you can see the profile of the superior canal and see the lumen of it. And this is more of a 3D type of CT, micro CT for these gerbils. Here at day 3, and I'm going to focus on this area right here in the superior canal. You can see the fenestration here, but you can also see the bony early regrowth of the bone in that space. By day 10, you can see that the canal has recovered, resurfaced itself with no obliteration of the superior canal. And so here's the control. You can see how thin the bone normally is, but it is thicker bone that regrows to reconstitute the superior canal in these animals. And so again, I was puzzled by this initially, but had to go back to the old fenestration literature. And Shambo wrote a lot about failed fenestration procedures for otosclerosis. And there were 2 main factors that he identified in terms of the bone regrowth and closing the canal again. One was bone debris left in that space, and the other is that the fenestration was too small. And so now we've been able to use sterile lactated ringer solution to remove some of this bone debris, but it's been impossible to remove all of it, but that's stretched out our ability to have the window of dysfunction. And so I'm not going to present any data for these 2 papers, but did want to just highlight what we did and what we found. And so we did a number of behavioral tasks. And so we did both auditory tasks and visual tasks. So we included visual tasks because we hypothesized, well, if the hearing loss played a role, even though it's unilateral, maybe that would adversely affect the decision making in these animals because they couldn't hear. But it turned out that wasn't true. And so they had impaired decision making during the time the canal was open for both auditory and vestibular tasks. And that was a paper that we published in Frontiers in Neurology in 2023. Most recently, we focused on the vestibular dysfunctions. We did a number of behavioral paradigms of balance tasks for the gerbils and found a statistically significant worsening of their ability to maintain their balance early on that recovered as the canals closed. And in both of these, we did studies measuring the degree of bone regrowth over time in these animals. And so to conclude, the CT-positive superior canal dehiscence and other sites are important. The CT-negatives exist. The phenotypes are the same. The sequelae, the vestibular asymmetries after repair, the cognitive dysfunction and spatial disorientation is reversible. The autophony is reversible. The nausea is reversible. Their migraines resolve or markedly improved. And typically these patients have uncontrolled migraines that no amount of medical management is able to control. But migraines are a relatively common disorder. And so there are patients who had migraine, who had exacerbation of their migraine because of the third window. And those patients then go on to be able to be managed medically. And finally, we've established an animal model of superior canal dehiscence. And this is important because it really isn't known the neurologic pathways that are disrupted that cause the cognitive dysfunction in our patients and the spatial disorientations. But now we have the tools to be able to explore these neurologic pathways, and that's what we're doing right now. And I'll close with another favorite historic figure in medicine, Osler, the first chair of medicine at Hopkins. And one of my favorite quotes of his is, if you listen carefully to the patient, they'll tell you the diagnosis. And this is definitely true with patients with vestibular disorders.